So BRIDGE-CV is what we call an implementation science study. So that's a study aimed at quality improvement of the care of patients with established CVD. We use a type of design which is called the cluster randomized design. So it's a cluster randomized trial in which we randomize clusters or institutions to either a multifaceted intervention aimed at quality improvement using different tools or to usual care, routine care. So we have a lot of evidence showing that antiplatelet therapy, statins, HAS inhibition, beta blockers, all these interventions can reduce events at the long term. And they are the basis for major guidelines. But the problem is that implementation of guidelines in clinical practice is suboptimal. So usually we find when we do registries, care gaps. So this is a study aimed at improving the uptake of these guideline recommendations, basically these evidence-based therapies. Once again, this was a cluster randomized design, and so we included 1,619 patients with established CVD. So these were patients with previous coronary artery disease, peripheral artery disease, or stroke. So these patients were included in 40 clusters. So these 40 clusters were randomly assigned to this multifaceted quality improvement intervention or usual care. And the primary endpoint was adherence to evidence-based therapies. And we define that as complete adherence in patients without contraindications to aspirin, statins, aspirins or antiplatelet therapies, statins, or ACE inhibitors or ARBs. The three together using what we call the all or none approach. So in order to meet the endpoint definition, patients need a prescription of all three therapies. So the multifaceted quality improvement intervention included different components. So one component was case management, usually conducted by a nurse. So before the physician visit, the nurse conducted a pre-physician visit using a simple checklist, a simple form where she could, register or identify care gaps in terms of the incorporation of the evidence. In case she found gaps, she then prompted the doctor saying, look, this is a patient with a history of MI. He's not using aspirin, so maybe you need to review that. So human prompting. Then the patients were seen by the physician, and the physician also used a simple decision support tool which summarizes in one page with different colors, so very useful to review and to use in clinical practice, major guidelines and recommendations. So this was, because usually our guidelines are very complex. They're 400 pages long, over 300 references, a lot of difficult pathways. So we try to put that together in one page. So it's a systematic approach, right, based on behavioral marketing. So pre-physician visit by a case manager, prompting out the doctors in case care gaps are identified, and then a decision support tool to help patient evaluation by the physicians. Besides that, we also provided sites with audit and feedback reports monthly on performance. Performance, I mean, uptake of EBM therapies, and also we provided educational materials to patients in terms of lifestyle modifications. So at baseline, we had a baseline survey showing that only 52.3% of patients from these clusters without contraindications were using statins, ACE inhibitors or ARBs or antiplatelet therapy. So almost half of the patients were not receiving a prescription for therapies that can really reduce the risk of major events. 12 months after intervention, complete adherence to statins, antiplatelet therapy, or ACE inhibitors or ARBs in control clusters were about 58%. So slightly a 5 to 6% increase, small increase. While in intervention clusters, control adherence to these therapies went up to almost 79%. So a 21% absolute increase, which was highly statistically significant. Of course, when we measure secondary endpoints, which was adherence to these therapies individually, so prescription of aspirin, statins was also improved. We also seen an important improvement in smoking cessation in these clusters. We haven't seen better risk factor control. Nevertheless, I mean, the uptake of evidence therapies were clearly improved in these patients from intervention clusters. If I can do an analogy, usually in airlines are very concerned about safety as we are in healthcare. So they use simple measures. So usually you have a flight attendant prompting passengers, put your seats in the upright position, fasten your seat belts, please turn off your phones. And she prompted and she checked every seat. They have that safety cards in airplanes, which is simple, one page, colorful, simple to understand, right? And usually the pilots, irrespective of their expertise or experience, they usually do checklists and they also prompt each other. So this is a systematic approach that really can prevent bad events from happening. So by using a simple systematic approach that can be readily available because it doesn't rely on, expensive or complex technologies, this systematic approach can really result in improvement in the uptake of important therapies. And we know that these important therapies saves lives. They really reduce events.